Specialty Mental Health Services Oversight and Monitoring. We're on page 16 of the agenda.
Dino Cocos-Gonzalez is going to join us at the table along with Brenda Grealish. I just want to say, when we talk about both CCR and what we'll be talking about later on this afternoon on our organized drug Medi-Cal waiver, the renewal of our 1915 Specialty Mental Health Services waiver was also both evolutionary and revolutionary at the same time, in that they gave us a 5-year renewal, but with that 5-year renewal comes a lot of expectation, and that's what obviously this budget proposal is seeking to do, is to implement some of the oversight and staffing and monitoring capabilities at the state level for these various county mental health plans. It's something that I think in hopefully not too long of a time, we will be coming and talking to you about how much more closely aligned these county mental health plans look to our Medi-Cal managed care plans on the other side, and that we are really crafting oversight and dashboards and other quality metrics that are similar on the other side of our managed care house, and that's kind of what our expectation is going forward. And so, you know, Dina can obviously step through some of the work that she will be leading, but I think that the federal government looked at this renewal of a waiver and some of the work that we've already done in California to say, you know, they expect better transparency and metrics, of which we are wholeheartedly in agreement with. And so that's really what we're committed to do with a lot of this work.
Good afternoon, Madam Chair. Dina Cocos-Gonzalez, Chief of the Mental Health Services Division within DHCS. And the department is requesting 13 positions and funding for contracted clinicians in order to implement the requirements in the special terms and conditions. The resources will assist in the additional work that's required in order for us to enhance and make the system improvements to our monitoring and oversight of the county mental health plans. As Director Kent indicated, the Centers for Medicare and Medicaid Services did approve a 5-year waiver for the first time, which is super exciting, and the waiver is effective through 2020. With that, because of some overarching concerns and expectations from CMS that we will be making significant improvements within the Specialty Mental Health Services program, they did issue special terms and conditions. The special terms and conditions require a substantial amount of workload, and therefore the additional resources are necessary to do so. The special terms and conditions, really the spirit of are around transparency, timely access to services, and overall improvements, as well as CMS is looking to have the department establish a process for sanctions, fines, and penalties. So I'm just going to go through your questions, and we do want to acknowledge that most of the discussions at this point around the special terms and conditions have been with the mental health plans and with CMS. Based on the nature of the discussions with CMS, we really felt it was important to work with the with the governmental entities and really get together on a game plan and looking at standards and making sure that what we were considering is something that is actually doable and can be implemented. We will be expanding the universe to include stakeholders and engaging and being transparent with stakeholders and also getting their input, and we plan to do so within the next month or two.
And as you go through the questions on page 20 of the agenda, once you get through them, if you would circle back, and you'll see in your agenda, starting on page 19, some broader kind of comments from staff. I want to make sure that we touch bases, that you respond to those 3 as well.
Okay.
I'm sorry to interrupt you.
Happy to do so. So DHCS is currently developing the required special terms and condition website. This is in relation to are we posting or when do we plan on posting the corrective action plans and the quality improvement plans. So we have not yet finished development and going live with the special terms and conditions website that we're in the process of developing. But once we do so, we will post those plans. We have collected them from the counties, all the quality improvement plans and the corrective action plans. Obviously, it's as the counties have their reviews, get their reports, and then submit their corrective action plans. So as soon as we're ready to go live with that, that web page, we will be posting them. We know it will be live by September 1 because that is the due date to post the dashboards.
So we're thinking September 1 or sooner of 2016.
Yes, that's correct.
Got it.
And for working with stakeholders on the development of the dashboard that's required by the special terms and conditions, again, we've been working internally, looking at our managed care partners and their dashboard and really just trying to become smarter because we've not done this in the mental health arena yet. And so we're just trying to leverage within our own department some of the dashboards and information. So again, within the next month or two, when we open it up and start engaging the stakeholders on the broader special terms and conditions, this will be a point of discussion. We will be discussing the dashboards. And the dashboards will be able to identify disparities in treatment, access, and outcomes. And I guess I would say in combination with the performance and outcome systems that you will hear Brenda Graylish speak to. But we don't look at the dashboard individually and the performance and outcome systems individually. Eventually, it'll be one rich wealth of information that we will use that will be able to identify the disparities in treatment, access, and outcomes. I'm going to turn it to Brenda, who's going to address the next question.
Thank you. Good afternoon. Brenda Graylish, Assistant Deputy Director, Mental Health and Substance Use Disorder Services, DHCS. Question 5 asked about the assessment or DHCS's assessment of the slow rate of growth of unduplicated adults receiving specialty mental health services and how DHCS monitors this. And I think that was, the question might have been anchored on some of the data that's presented in our supplement, specifically on pages 26 and 20 through 28 that shows kind of a flat trend line of adults. Just wanted to point out that that doesn't include ACA. These are only individuals or adults who are billed through the short Doyle Medi-Cal system. So it doesn't include any of the growth that's occurred in the ACA. The reason for that is because we haven't had enough data to be able to roll that into the projection, but we will for the November 2016 supplement. So in the interim period, what we've provided later on in the supplement, beginning on page 40, is just some basic descriptive information about the ACA population. So I'll point to a stacked bar chart that's on page 42 that shows the ACA population and the non-ACA population. So you'll see that that ACA population that's shown on page 42 is what's going to roll into that projection. So we'll see those moving forward beginning this fall. So.
But if we go back to page 19 of the agenda under limited caseload growth,
19.
just flip back page 2 there. The average of 6% for the same time, that second to the last sentence,
Same population.
that's not including ACA expansion. I guess my point is like it's the problem is bigger than just the expansion into ACA.
Oh, okay. So I think we'll have to do some research. Yeah, I'll have to look.
I mean, you see what do you get my question?
Medi-Cal grew and
Your request is really more to the overall growth in the population that also would come from the woodwork effect and not just from the 100% expansion population.
Right.
So
Right.
I think, we had a couple of things, and some of our data warehouse people may have to pull some other elements, but I think one premise that we were working off of was, given who typically comes through the short Doyle system, those are individuals with obviously serious mental illness, and so that's a known population.
Right.
In that the percentage of the population overall that's impacted by those specific diseases may be fairly stable. And so, there's a couple of different changes that we're looking at in terms of the growth in Medi-Cal, in terms of you had a lot of adults join, but those are in many cases working low-income individuals who may not otherwise be disabled from a serious mental illness. So we had a couple of premises that we were working to see if we can actually have the data validate that, or if there's something else that's amiss. And so I think, more on that when we do a little bit more digging.
So I'm understanding the question better now. So a 6% growth in Medi-Cal population may not necessarily translate to a 6% growth in a specialty mental health SMI population. I think that's what, am I articulating that correctly?
Go ahead and answer the question. I want to make sure. Go ahead.
Go ahead, Michelle.
Right, so it's the same population. So the non-optional expansion, the average growth rate for the Medi-Cal population was 6. We had 12% one year, 2% for that same time period, and we're showing less than 1% growth. And the question is, are you looking at that? Are you evaluating, is this growth rate happening? Should it be happening? I mean, there's been no change really in the unduplicated client counts for especially mental health. And just, are you even looking at that is really the basis of the question.
Well, and to the other parts of the data that are not captured by the short Doyle system is we're also looking, and this is a different part of the department, but the claims and the utilization data around the mild to moderate claims for adults that are now handled by the Medi-Cal managed care plans. So what you have seen is, as individuals have been enrolled into the program and begun seeking services, we are also trying to understand there has been increase in growth in that utilization of that benefit. Obviously, every benefit is a little slow to start, but as it gets more, entrenched into the overall benefit package, you start to see greater utilization, and I think we have seen that, and so that helps us understand also what is happening on the SMI side.
We'll just have to keep monitoring it.
Okay. But know that that's the lens that we're seeing it and the concern that we continue to have.
And further data analysis on our side, we're happy to work with your staff and come back with some better, either better detail or better data.
Helpful.
Okay. Question 6, how does DHCS monitor if a county mental health plan fails to authorize all medically necessary services requested to meet the needs of children? And the department looks at the mental health plans, grievance and appeals reports, and monitors those. We also look at the ombudsman call data, and we look for patterns and trends and see if based on that data, if we see issues. We also have a triennial system and chart reviews where we're reviewing the provision of specialty mental health services. And again, if we see any patterns, any trends, anything that could possibly look concerning, we work with the county, providing technical assistance or talking with them, and if needed, even we'll have the county do a corrective action plan.
So that was what I walked away after reading the agenda, was what is the state doing to guarantee that the counties are providing these mandated services? So there is a stick, if you will.
There is, and there's a lot of discussion with the county mental health plans, and obviously with implementation of KDA and children's services and EPSDT, there's a lot of dialogue. But yes, there is a stick with the reviews and corrective action plans. Question number 7 about monitoring referrals and whether there is a follow-up by the county mental health plans or a provider. This is a great question, and this is an area that we do need to look at further and where probably we need to do some more work.
And you'll get back to us once you have done it and are clear?
Yeah, I think when we talked about this when the agenda came out is I think what we're struck by is the referrals come to the county from a variety of sources. It can come from a primary care physician on the Medi-Cal managed care side. It can come through a different county agency obviously if it's a child maybe in the welfare system. And so there's not necessarily a warehousing of referrals. So that was the first question that we were struck by. And then in terms of once an individual is enrolled and is utilizing services in the county system, it was more of a IT-related system question where we were like, from time of referral, if we knew a referral had taken place and from who, what was the time lag in terms of either an appointment or a follow-up or things like that. And so I think some of these things are metrics and outcomes that we ourselves are acknowledging that part of the overall workload associated with the implementation of this waiver is all around how we do data, and some counties may have a better and more sophisticated way of tracking that data today, some may not, and so part of it is having a standardization across all the different county mental health plans. And so it is a great question, and I think one in which we acknowledge we just need to do more staff work internally, but also it probably leads us down a path of an IT types of capturing the data system.
Got it.
The next question is about DHCS's timeline for releasing the information notice regarding timely access standards for mental health services, and the department plans on issuing that information notice within the next couple of months. We are wrapping up the work around the timely access standards, and then we'll be sharing that with our county partners, stakeholders, and then getting that information notice out soon.
So one question I had on 8, because on the health side, we have Knox-Keene. And so are you kind of starting from scratch, or are you looking at Knox-Keene as a perhaps methodology, a process that you too could utilize?
We are looking at Knox-Keene with the expansion of mental health services into the managed care plans for the mild to moderate. It really has allowed us to look more with the managed care plans, working closer between mental health plans and managed care plans, and we totally think it makes sense to align these standards where appropriate, even though the mental health plans are not required by Knox-Keene, but we definitely are looking at aligning standards.
As a template.
Absolutely.
Used on the other side of the house, if you will.
And these standards do include follow-up appointments.
And so what's your timeline? Did you give me one?
Within the next 2 months, if not sooner.
Okay. Thank you.
There's, as you can tell by the time, there's a lot of work going on right now.
Simultaneously, I get it.
So, okay.
I'm not pushing, but I just would like to have a sense of the time frame.
Yes. And the next question about DHCS monitoring and assessing trends in mental health and ombudsman calls. So we do have a database where we collect the number of calls, the types of calls, where we look at the categories and any trends that we receive as a result of our ombudsman calls. And when and in assessing the reports and that data, we look again for trends. Is there a particular county? Is there a particular issue that we're seeing? And depending on what we're seeing based on the trend, most commonly it's about having our county support folks reaching out to the counties, working through the issues, and really identifying if there's technical assistance, is there a misunderstanding. Also, if we look and we see that there's a trend in a particular area, we use the forum of our county work groups to discuss those issues and make sure we're all clear. And if necessary, and we see that our previous guidance isn't quite as clear as it could be, we will consider then issuing additional guidance that provides the clarity necessary.
And how often is that occurring? I'm trying to get a sense of the frequency of problems.
So I wouldn't say that we see a significant pattern of issues that come in. I would say that that we follow up on a regular basis with counties just because we want to address the beneficiaries issue and make sure that we are clear on what's happening and that the counties are aware of the beneficiaries issue. But as far as patterns, we haven't really seen any significant patterns. It's really mostly about calls coming in for how to access services and the linkages and questions in general about Medi-Cal and anything, any program or new thing that's being implemented.
Okay.
The other thing I will say is that with all the integration efforts that are happening within the department, one of the things that we are looking at doing is having the mental health ombudsman roll into the larger department ombudsman office.
Okay. And final question, 10?
I'm sorry?
And the final question, 10?
And the final question, well, first, my apologies for the delay in providing the information that has been requested. And we were just in the process, they're living and breathing documents, and we wanted to provide the latest and greatest, and there was some work necessary. So we are at the point where we should be able to share the information requested within the next week.
Got it. Thank you.
And Madam Chair, you had asked to circle back to page 19, and I know Brenda addressed the case growth issue. Number one, about the broader engagement of stakeholder community and that it's critical, and we absolutely agree and know that it's critical and want to engage our stakeholders very soon in working with them on the special terms and conditions. The mental health plans is who we have our contractual obligation with, who provides services, who we oversee, and there just needed to be some foundational work with CMS, with the MHPs, but we definitely always had planned and look forward to engaging our stakeholders.
Do you already have a kind of an ongoing infrastructure that you tap into stakeholders? You already have kind of your group, your people?
We do. And I just addressed the last issue 3 with the information requested.
Excellent, thank you. LAO. Finance. Any public comment?
Madam Chair, and I guess just Madam Chair only at the moment, Rusty Seelix, California Council of Community Behavioral Health Agencies. As a stakeholder group, we look forward to the participation, but I wanted to highlight 3 populations that should be low-hanging fruit to get to in this that we're not. People discharged from jail. The LA County Sheriff was on TV years ago saying, on an average day, I discharge 100 people into the community that I know have serious mental illness and need help. I contacted the county, they had slots for 1. Now, at that time, that was before the Affordable Care Act, most of those people weren't Medi-Cal recipients. Now almost all are. They have an entitlement to services. It seems to me this system ought to be able to track those people and make sure that everyone discharged from the jail who the jail found was a Medi-Cal recipient with a need for mental health services got a treatment plan and got services in a timely manner thereafter. Similarly, people discharged, we used to say hospitals, now I will say crisis care, because it's not, same thing. What they often get is the name of a doctor and maybe a referral. How many actually get care and how many get the right care?
Right.
In other areas of health care, you step down from a hospital crisis care and you get fairly intensive outpatient services. We have that. It's the full service partnership model in the Mental Health Services Act. That doesn't tend to be a norm in any county, that when somebody is coming out of crisis care, that there should be a plan to put together a comprehensive treatment plan. With children, what we hear is there's an initial assessment done, but then there's an informal wait list. Now, no county would ever say it's a wait list, but they don't get their actual referral and treatment from one of the intensive service providers they need until there's an opening in one of those programs, and it's often several weeks. So as we establish standards for timely access and follow-up appointments, there should be no gaps. If somebody needs care soon, then we should be able to track that and make sure that happens. These are just 3 examples of the kinds of things we hope to engage in and hope that through the legislature and the department will be able to change these paradigms. Thank you.
While you say there's low-hanging fruit, we're also talking about significant numbers of people.
Significant numbers of extremely vulnerable people, absolutely.
Thank you, Mr. Felix, appreciate that. We'll move on to issue 4, performance outcome systems for Medi-Cal specialty mental health services. We're on page 21 of the agenda.
Thank you. Brenda Graylish again, DHCS. So the performance outcome system, question 1, please provide an overview of the proposal. So this proposal is linked to work that we set forth in our performance outcome system implementation plan, and then we provide an update in our system plan for our goal to identify a functional assessment tool to be able to track child and youth functioning over time and changes as a result of the services provided to these children and youth. So we've been working with UCLA. We have a contract with UCLA to perform a study. There's 2 phases to this study. And we've almost finished phase 1, which has been an extensive lit review and scan of the counties, scan of the nation, of kind of the state of the state. And we're about ready to embark on phase 2, which is a modified Delphi panel where folks are going, subject matter experts are going to be reviewing the tools to ultimately come up with a recommendation for the state of California to have a tool or set of tools. We're not quite sure how that's going to work at this point because we anticipate receiving their recommendation in the late summer, early fall. So this proposal is to provide the funding necessary to the counties to be able to develop their infrastructure, to be able to collect this information. So we know that counties are going to have IT or information technology needs to be able to augment their data systems to be able to collect this information, as well as training needs, and then ultimately the additional funds to actually have clinicians or whomever will be administering these tools to actually complete them and submit them to DHCS. So that's question. Question 2, when will county-specific data be reported? It was previously reported to the committee that these reports would be posted in February 2016. That was our initial goal. We had put the data out that we produced reports for all the counties, gave them to the counties, and asked them to review the reports for accuracy. Some of the counties had asked for some extensions for some additional time to be able to take a deeper look at their data, and it was actually a very fruitful process. The counties had identified 2 tables where we needed to add in our fee-for-service data. So what we're doing now, and we're almost in the process of finishing it up, is we're kind of putting a coming soon where those tables would have gone, and we'll post the reports. We're going to move forward getting the rest of the data posted, which we anticipate happening in May 2016. And then while that's going through the approval process, our team is updating those data tables, and so we're planning to be able to post it with fee-for-service data by June 2016. So it was a good process, and many counties were engaged, and we were appreciative of it. So,
Right.
Yeah. So question, did I get everything on that one, I think? Yes, okay.
Moving on to question 3.
Great. Question 3, when does DHCS plan to delineate foster care information in these reports? So we've created foster care reports, but while our team was creating the foster care reports, the global data sharing agreement with CDSS was put into place. So what we're planning on doing right now, CDSS, our Department of Healthcare Services, has been working on a automation process so that we'll be automatically getting feeds of the DSS data into our DHCS warehouse. That process is about ready to be finalized within the next couple of weeks. And so what we're going to do is, since we're going to have direct access to that CDSS data, we're going to validate, because we were using aid codes in our data, in the DHCS data, we're going to validate to make sure we're picking up the same kids that CDSS picks up, or actually has in their data set. So we're just going to do a validation or kind of like a reliability check between those data, and then we're hoping to get those reports out by the summer, so if not sooner. And question 4, what are some of the findings from the September 2015 report that DHCS has taken action on? I don't know so much the findings, but it's more the data. We've learned a lot about our data, not just even from the September 2015 report, but even the February when we came out with the February 2015 report. We actually had realized at that point, after we released that data, that the fee-for-service information was missing from our time to follow-up. We didn't realize that it was going to impact our psych inpatient tables as well. That was what was realized by the counties, because once we started chopping that data into a more granular level, then it became more obvious that that data was necessary. So it's really been kind of a quality improvement process on our actual reports. But what this also speaks to is a quality improvement process, because as part of our performance outcome system, it's not just about the reporting, but the quality improvement, the quality improvement process, and it's exciting. And so we had encountered some challenges in staffing for the QI process. We had requested and received 2 positions for the quality improvement. One was a consulting psychologist, and the other one was a health program specialist too. And it's been quite difficult to find qualified staff to be able to fill those positions. We just recently filled the consulting psychologist position as of March of this year, so that's exciting. And our HPS2 position we're still recruiting for, but we have an exam, so we're hoping that that's going to result in a qualified candidate to fill that position. Even though we've had these limitations, we've still tried to move forward on a quality improvement process. So our existing performance outcome staff have started working on putting a QI process together. We presented a kind of draft framework at the State Quality Improvement Committee conference that the counties hold. And we've also, through our subject matter experts work group, through the performance outcome system, just kind of gave them a heads up at the last meeting that that's something we're going to be diving into, especially now since we have our consulting psychologist who can lead the efforts. So we're expecting this year's really going to focus on getting that QI process in place. And then anything else on that one? Or okay. Why was the development, question 5, why was the development of the implementation plan update related to screening and referrals put on hold? It's just the report, the work is still being done. So we, in the system implementation plan and system plan update, it kind of put forward a framework for what we were going to be doing, the activities that we were going to be engaging in, and all of those have that framework maintains. So we've continued with our partner stakeholder involvement. So we have our monthly meetings with our subject matter experts work group and our measures task force. We've published our performance outcome system protocol, which we call the measures catalog. That's the documentation of how we're analyzing and reporting the data. We're continuing to do our reports that we said we were going to do using the existing data. We've got our UCLA study for the functional status measurement tool, and then the quality improvement process, which I just discussed. And then specific to the screening and referrals, in the system implementation plan and subsequent system plan update, we had mentioned that we were working, we were starting to work with our managed care division. So we have our specialty mental health or mental health services division, but then in managed care, there's a whole other team that's working on just managed care, and they can focus on mental health. So we had set forth that we were going to be meeting and doing a cross education, and we really spent the bulk of 2015 trying to understand one another's data systems. And with the Medi-Cal managed care dashboard, that was great because they started incorporating the mental health data, so that really informed those discussions. And in the meantime, we didn't have a lot of ACA data to look at between the two systems because the claims were still rolling in. So now we don't have a fiscal year's worth of claims, but we have a calendar year worth of claims. So what we've done is we've kind of done a proxy examination of the data, looking at how people, how the ACA and the mild to moderate benefit has expanded that population, and then how folks are utilizing services between the systems, so within and between the systems. So we've got a draft report that we're hoping to put out to our subject matter experts work group at the next meeting so that they can start kind of having that feedback or provide some feedback to us, but also it's going to be an educational process. We're going to have to take what we've learned and impart that knowledge onto our subject matter experts so then that we can have more informed conversations about how best to move forward with screening and referrals. So yeah. All right, anything else on that?
Not on that. Final question, number 6.
When does DHCS plan to incorporate Medi-Cal managed care plan mental health screenings and referrals into the POS? So that's kind of the same thing. So like I said, we've developed this proxy measure, and we're going to kind of start with that as a point of departure and use that to grow the conversation.
Thank you. LAO? Nothing? Finance? Public comment? Here she comes.
Good afternoon, Madam Chair. Adrienne Shilton with the County Behavioral Health Directors Association. CBHJ is very supportive of the Medi-Cal Performance Outcome System project. I think it's important on 2 levels. One, to better understand outcome data associated with this population of children and youth, and also to look at standardizing data collection methods. And so the reports we've seen at both the statewide level and the draft reports at the county level, I think are tremendously valuable. And as DHCS mentioned, I think it's a quality improvement opportunity as well for county mental health departments. So thank you.
Thank you. Mr. Selix.
Yes, Rusty Selix, California Council of Behavioral Health Agency. I wanted to stress the importance of those last 2 items, numbers 5 and 6, with the managed care plans. We believe that that's where we will find all the people we're not serving and then create a process to make sure we serve them. If you screen everybody when they come through primary care or the emergency room, if they don't have a primary care physician, then you should see everybody. And when you see them, you should be able to identify who has a need for behavioral health services, and then we should have a system to make sure those needs get met. So we're very much looking forward to that piece, which could then help with all the other pieces we need. So this is a very important program, and it will complement, I guess, the soon-to-be-released physical health behavioral health integration plan across all of Medi-Cal, because that's where all these people are, and we've got to get them into the mental health system. It's, it's over and over again the same theme. Why are the numbers of people we're seeing not going up? It's really a serious problem, and this is a key to getting to it.
Thank you, sir. Appreciate that. Let's move on to item 5.